we're starting his talk, and over to Dr. Agusi.
Thank you very much. Now I will share.
Unmute.
Hello, can you see my slides? Can you see my slides?
Yes, sir.
Okay. Now, first of all, good evening to everybody and respected chairman, sir, Professor A.K. Pandey, Professor R.K. Sinha, and the moderator, Professor D.P. Singh, and host of galaxy of other experts in this field. In all the different specialty we have got in this meeting. So I welcome everybody and I am really grateful that you have given me the chance to speak on this subject. Now, my talk is on emerging and re-emerging causes of the fever, and second part is fever with jaundice. So, it is not moving. Yes, okay. Now, what I am going to do is in next 45 minutes, what my objective, I must tell you from beforehand. I will define the topics of discussion, enumerate common causes in each group, and outline of some important disease I will give you, because the list is so long that it is beyond the scope of discussion of the present seminar. It may take days together to complete the list of fevers. I will try to highlight the gray areas and I will give you some hint about approach towards management. Now let me define the emerging infectious cause of the fever. Emerging infectious cause of the fever means it's the outbreak of previously unknown disease, a new disease, or known disease with rapidly increasing in incidence or in geographical areas. Changed clinical feature and changed response to therapy. Persistence of infectious disease that cannot be controlled. These all 4 points come under emerging causes of the fever. Now the next is re-emerging infectious cause of the fever. Re-emerging means diseases which reappear after they have been on a path of decline, maybe due to breakdown in public health measure, from the government's fault or from our fault. Major change in the human behavior. We have seen how entire public was using mask last year, and now you see the scenario, change scenario. So this is the major change in the behavior, human behavior. Now you might get a re-emergence or the third wave or the fourth wave of the COVID-19. No wonder. Overuse of antibiotics leading to development of resistant strain. Now I will give you examples of the emerging and re-emerging diseases. The list is so long, but I have selected some of the important things, and among them I will discuss on few subjects. Swine flu, H1N1 influenza virus, avian flu, H5N1, Middle East respiratory syndrome, or MERS is a coronavirus. SARS, severe acute respiratory syndrome, is again a coronavirus, and our commonest enemy, number 1, COVID-19. Then we have other viral diseases like Nipah virus, Chandipura virus, Chikungunya virus, Zika virus, Hanta virus, hepatitis C and E, hepatitis HIV 1 and 2, Lassa fever, Ebola fever, and Marburg hemorrhagic fever, Crimean Congo hemorrhagic fever. But I am giving you the list of the diseases. I am not going to talk on everything because there is no time for that. Now we have got a bacterial disease as well, diphtheria. We had forgotten, but again there was surge in diphtheria in Andhra Pradesh, Assam, Delhi, Gujarat, Karnataka, Nagaland between 2001 and 2015. Plague we had completely forgotten, but there were reported cases from Himachal Pradesh and Uttarakhand between 2002 and 2004. Tuberculosis, the resurgence in incidence or difficult to treat disease has come up. They are called MDR or XDR TB. Then we have vancomycin resistant Staph aureus. It's very, very difficult to treat. Legionella pneumonia. Then we have our very old enemy, that is Plasmodium falciparum or Plasmodium vivax. They are ACT resistant, artemisinin resistant strains have come up. So it is so difficult to deal with these pathogen that we have assembled together to get some few idea and to imbibe some new ideas, and I should get some input from the audience, and I would also like to give some input from my side. The swine flu, it was a dreadful illness, orthomyxovirus, one of the deadliest infection disease in past decade, pandemic or endemic form. Global health burden, human to human spread is possible. WHO declared the pandemic in 2009. It is swine flu is named comes from the first case reported from the swine. It is spread from swine, that is pigs, in 1930 in USA. Again from 2009 the pandemic originated from Mexico. So it is a very, very infectious disease, and we have seen how it was spreading in India as well. People traveling in a closed air flight space, anybody coughing or having fever with swine flu, they were very easy to infect others. I have seen and experienced the people who have suffered from this. Clinical feature is very similar to any flu. They have mostly common features like fever, chill, upper respiratory tract symptoms, malaise, myalgia, headache, shortness of breath, tachypnea, vomiting, and diarrhea. The diagnosis is by RT-PCR method. The differential diagnosis, host of the viral diseases come and the differential diagnosis. Complication is very important. It can lead to diffuse pneumonia, it can lead to respiratory failure, cardiovascular system can be affected, and patient may develop myocardial infarction and sudden cardiac death, and also encephalitis. So it is a very, very dangerous disease. FDA has approved treatment, oral oseltamivir, inhaled zanamivir, and IV peramivir. These three drugs have been FDA approved, and we have got fortunately oseltamivir available in India in oral form. It is easy to use it, 75 milligram BID for 5 days at least, in the very beginning. Most fatalities are due to secondary bacterial pneumonia, when the patient suffers from prolonged fever with high leukocytosis. Staph pneumonia is probably the reason, and it is a very serious, carrying very serious prognosis. Then the fatalities could be due to viral myocarditis. It could be due to viral encephalitis. The prophylaxis, fortunately, is influenza vaccine. So I would request everyone to start taking influenza vaccine once a year. It helps really a lot. SARS is severe acute respiratory syndrome, is a major epidemic in November 2002. More than 8,000 cases were reported. Respiratory route of infection is by aerosol. Incubation period is approximately 7 days. It lacks upper respiratory tract features like coryza and sneezing, etc. The non-specific features are there: fever, malaise, myalgia, chill, rigor, cough, dyspnea, and watery diarrhea. It is a new coronavirus. It's called H coronavirus NL63. Mortality rate is very high, 9.6%, and is all due to respiratory failure. Diagnosis again by RT-PCR or cell culture. There are two supportive treatment is steroid and oxygen, and definitive treatment is ribavirin, lopinavir, ritonavir combination, and ultimately the respiratory support. Then again, very similar to this, SARS is the MERS, Middle East Respiratory Syndrome coronavirus. Is called MERS coronavirus. It is again respiratory route of infection, but has emerged from bat originally, and there is a reservoir, principal reservoir in Middle East is camel. Person to person transmission is possible. Earliest case identified in 2012 in Middle East. Death rate is very high, alarmingly 36%. Incubation period is only 5 days. Usually the age is approximately 50 years, and underlying medical condition is very important: diabetes, hypertension, coronary artery disease, chronic kidney disease, immunocompromised status likewise. Clinical feature: the dyspnea is very important, cough is very important. Lab data shows low platelet count, low lymphocyte count, LDH is high, and the liver enzymes are raised. The chest X-ray shows universal changes. It could be patchy infiltration, it could be diffuse pneumonic changes, it could be ground glass appearance, or so many things. Just like any other viral respiratory involvement. Serology, RT-PCR method. Respiratory failure is very, very fast, and it is much faster than SARS, that is severe acute respiratory syndrome. High percentage of the cases requires ICU treatment and ventilation. Treatment is again broad spectrum antibiotic, steroids, interferon, ribavirin, lopinavir, and ritonavir. So the death rate and the mortality is very high in MERS as compared to, it is 36% in MERS, similar type of virus, and in the SARS it is 9.6%. Avian influenza. Avian influenza is also giving a lot of hard time because birds are natural source, endemic in poultry, difficult to differentiate from common influenza. History can give you only clue. When a patient says that he has come in contact with the ill birds or dead birds or live poultry in previous 10 days, then only you must think of avian influenza. Human to human spread is also possible. Symptoms are similar, GI symptoms is there, prolonged febrile state, malaise, a lot of malaise. Cause of death is respiratory failure, and MODS is multi-organ dysfunction syndrome and septic shock. The diagnosis is by RT-PCR and from the throat swab or from bowel, bronchoalveolar lavage. By culture, treatment is similar, oseltamivir, piramivir, but there has been reported cases of drug resistance in this virus. Convalescent plasma can be used. Now comes our commonest enemy, number one, or the enemy of the entire world, which created pandemic and created lot of morbidity and mortality in the entire world. It is the SARS-CoV virus 2, and first reported in December 2019 from Wuhan, China. It's by aerosol spread. Exhaustive literature is there regarding COVID-19. Still under research. Still we are not very sure. I am not going to discuss about the COVID-19 as such. I will just tell you because it is a huge chapter and all of you are very, very much learned about COVID. After treating hundreds and thousands of the cases of the coronavirus, you are very well aware what is going on. But I will just say it has got a usual clinical feature: malaise, fever, loss of taste, loss of appetite, body ache, retroorbital pain likewise. Severe disease, if the patient is moderate or severe disease, then shortness of breath, tachypnea, low oxygen saturation, ARDS. And in critical disease, there is respiratory failure, shock, and multi-organ dysfunction syndrome. Now, what I am going to discuss in the COVID-19 is about the fever management. Fever management is at times very cumbersome. COVID-19 is often complicated by co-infection in 19% of the cases and super-infection in 24% of the cases. And the mortality is already, we know, is very high, but mortality increases much more if there is a co-infection or super-infection. Now, after treating the COVID-19, your RT-PCR becomes negative, you feel happy, and then suddenly the fever comes up and you start scratching your head. What has happened? Everything is fine. What is co-infection? Co-infection, recovery of other respiratory pathogen at the time of the diagnosis of the COVID. If you can get some culture from sputum or the inner specimen, you can find out that there is a bacterial, viral, or fungal infection. Why examples I have given, and it is seen in 19% of the cases of fever. Klebsiella pneumoniae, Streptococcus pneumoniae, Staph aureus, influenza type A and type B, respiratory syncytial virus, and the fungus is Aspergillus, there was a hue and cry about black fungus. This chapter, this topic has come recently in limelight about the co-infection and super-infection cases. So these are the examples of the co-infection, and it is seen in 19% of the cases. Now, super-infection. Super-infection means the recovery of other pathogens during the treatment of COVID-19. And examples are seen in 24% of the case. And the very, very important bacteria is Acinetobacter species, Pseudomonas, Escherichia coli, rhinovirus, and the fungal Candida. So there is a fungus, there is a virus, and there are 3 bacteria are there. I think you must be recognizing Acinetobacter species and Pseudomonas, how nice they are in treatment. So now, COVID-19, I will now concentrate on Acinetobacter species. It is a real challenge for the physician. It is a real challenge for the physician. Acinetobacter baumannii is the aerobic gram-negative cocobacilli. What are the situations when the people get this type of infection? When they are treated in ICU setup, when they have used half-heartedly third-generation cephalosporins, quinolones, carbapenems, 1 or 2 shots of carbapenem. Many people use it in OPD. They give 1 shot of carbapenem, go home. Alcohol user, diabetes mellitus, smoking, chronic obstructive pulmonary disease, chronic kidney disease, cancer, immunocompromised status. Let me tell you, these bacteria are inherently resistant. They are born resistant. They are born tough to fight, give you a real fight, and the physician will have a trouble in getting rid of them. There are 2 types of resistance, MDR resistance and XDR resistance. MDR resistance is to 3 antibiotics, cephalosporins plus sulbactam, aminoglycosides, and quinolones. XDR, when we call it, when all the 3 plus carbapenem are resistant to this bacteria. So remember this, they are inherently resistant organisms. They are not easy thing to deal with, or you can call it hard nut to crack. Now, what are the clinical features of Acinetobacter baumannii? The hospital-acquired pneumonia, community-acquired pneumonia. They have got fever and lot of sputum. If you culture the respiratory secretions in a proper collection of this secretion, then you can culture it. X-ray chest will show either lobar pneumonia, patchy infiltration, or lobar or patchy infiltration, cavitation, pleural effusion. It can present as septicemia, skin and soft tissue infection, UTI, meningitis, and osteomyelitis. So you can see the list of the clinical feature of the Acinetobacter baumannii infection when it is in super infection. The COVID patient is already suffering, they're already weak, and on top of it, this is the hell, this is giving the hell. Now, what is the empiric treatment? Carbapenem is the first line of drug. We don't know whether it is resistant or not. And one thing about the special thing has been said about carbapenem, that is a meropenem brand, is in this infection, it must be used in a prolonged IV drip, 8 hourly, and the drip must continue for 5 to 6 hours, continuous flushing of the entire system with the antibacterial. So this is a very important. I look at the literature and they say that the difference in the prognosis or difference in the cure rate is hell and heaven if you give for a short IV push and if you give a prolonged IV drip. So this is the important thing you must remember. As they are inherently resistant, so we will try to give something else. There is a polymyxins, colistin plus carbapenem, colistin plus sulbactam, and carbapenem plus teicoplanin. I used in my patient carbapenem and teicoplanin with a very good result, and I could get rid of the fever after this infection. So I strongly suggest that the last combination is very good. Carbapenem 1 to 2 gram IV 8 hourly, and teicoplanin 2 to 400 milligrams slow IV BID. It is a glycopeptides. It comes as a thread preparation of targocid. Now, our very common friend, or not friend but enemy, is dengue fever. You have heard